Welcome to the Nurse Shark Academy Show, a Baxter Professional Services production. Welcome to the Nurse Shark Academy Show, where we're experts in nursing and experts in business. I'm Tina Baxter, your host. The Nurse Shark Academy Show highlights nurse business owners and others in the healthcare field who promote entrepreneurship. We interview nurse leaders and encourage them to tell their story. Today's guest is Jennifer Thietz. And today's episode, how one nurse went from the bedside to starting a movement to reduce nurse burnout. Don't forget to like and subscribe and to follow us on all of our social media. Nurses, are you burnt out, frustrated, looking for something new? Are you looking for more? Nurses, are you ready to feel the sun? You will dream big and expand your consciousness as an entrepreneur. Your nursing license is your key to freedom. Join the Nurse Shark Academy at the nursesharkacademy.biz today. Hello and welcome to the Nurse Shark Academy Show. I'm Tina Baxter, your host. The Nurse Shark Academy Show highlights nurse business owners and others in the healthcare field who promote entrepreneurship. We interview nurse leaders and encourage them to tell their story. Today's guest is Jennifer Thietz, and she is an author and has written several books. Just a little brief background about her. She's a master trained nurse and author, immigrated to California from South Africa in 2003, where she worked in acute care settings for 18 years. Most of that was at the bedside. So she has lots of experience regarding healthcare in the U.S. and the current needs of nurses. So I want to welcome to the show, Jennifer.
Hi there, Tina. It's lovely to be here. Thank you so much.
Thank you for coming. Now, we always ask that first question, that hard-hitting question, right? What made you become a nurse?
Tina, I knew that I wanted to be a nurse from early days when I was really young. I was exposed to a patient who had wonderful care at the age of about 6. And I remember distinctly being told how wonderful the nurse was and what the care was about and how they changed that patient's life. And it was instantaneous at that point. I thought, well, if I can do that for another person, another patient, then I want to be a nurse. And so that's how it started off.
That's wonderful. And so when you were experiencing that, was it something that you that was like always your thing that you wanted to do, or did you like have those other thoughts of maybe I wanted to be, I don't know, a firefighter?
No, I'm scared of heights. I couldn't be a firefighter. No, it was always nursing for me. It was something that I just knew in my being that I wanted, that I wanted to do. So I've been very lucky. I've been able to follow my passion. It's been a long career, and I still love nursing.
So did you study nursing in South Africa before you came to the US?
Yes, I grew up in Zimbabwe, which was the old Rhodesia. And when I was 18, I left Zimbabwe and started my nurse training at a hospital called Groote Hospital in Cape Town in South Africa. Our training in those days, Tina, was 3.5 years long, 3.5 years long, the training. And we were at the bedside for a lot of it. We would have blocks of college. 3 at a time, and then we would go back onto the unit. So we really learned hands-on. We worked as nurse assistants until we qualified as registered nurses. And then I got stuck in and I worked in pretty much acute care for those 15 years after I qualified. And then in 2003, we decided to immigrate. We were very, very lucky. I was offered an international position as a nurse in California. We moved to California in 2003, and I worked at the bedside for 18 years before leaving the bedside. And I've loved working in California in the States, but it has been tough at times.
I can imagine the healthcare system is probably very different than what we've had. We've had a nurse just recently on the show who is from Jamaica, who is a midwife, and she
Ah,
had um, a lot more leeway to do things because they had to. I mean, there was nobody else to do it, so you delivered those breech babies and you did what you had to do. And in the United States, everything is so regulated and who can do what and that type of thing. So I imagine that there was some difference. So can you kind of speak to that?
yes, there were differences. When I was at the bedside in South Africa, and I'm sure it's the same pretty much to this point. Um, we had less, I think, materially in the form of resources, and so we pretty much would work in a situation and do what was required of us. There wasn't time necessarily to find a physician if there was a physician available. It was a case of this patient is presenting, they need this, and the nurse would do it. The physicians were also they had a lot of confidence in us as nurses. They wouldn't be a lot of negative feedback. Obviously, with as long as we acted appropriately, we would get the support of our nurse managers and our physicians. So I was a bit surprised coming to the States. I understand why care is regulated, obviously. I think it's an important part of providing excellent care, but certainly it was not the same in South Africa when I was at the bedside.
The scope of practice for nurses differs. And the interesting thing about the US is that it can actually differ from state to state.
Right.
And I think for international nurses that are coming, it's a little bit of a culture shock
Yeah.
because what you were able to do in your own country, you're no longer able to do here. And I think sometimes, in some cases, you're probably a little bit more qualified to do it. I think than some of the
You,
physicians because you've had to do it. I was just
yeah.
talking about her delivering those breech babies. You
Yes.
don't have the option of a surgery, so you better figure it out.
You better figure it out. So in South Africa, we most of us trained as midwives automatically after our registered nursing. So we came out with a bachelor's in nursing and in midwifery, and or not a bachelor, sorry, an associate's in nursing and midwifery. And I can remember when I started training with my in my midwifery. Department, I had to do 5 deliveries with somebody, and then I had to sew up 5 episiotomies, and then after that, I was actually mentoring new nursing students coming in, and I would be with them when they were doing their five deliveries. So you can imagine, it was certainly you learnt on the job,
Yes,
and you prayed and crossed fingers that there wasn't going to be a challenging patient that you had to deal with.
yes. So when you came to the U.S., what specialty did you work in again?
I worked in medical surgical nursing initially, and then I got into oncology. I've done a lot of oncology through my years. I've been at the bedside 20 plus years of my 34 years of nursing. And so I've always looked at nursing as a bedside nurse. And leaving bedside nursing 2 years ago. So, when I say bedside nursing, when I was working in California 2 years ago, I worked in the hospital with a team. I was managing a team of oncology nurse navigators, but I was doing patient care too on complex patients. So I worked during COVID as well. I had the mindset of a bedside nurse. When I left and I was able to put my head up and actually start really, meeting people like you, Tina, other nurse leaders like you, I was able to see it. I was introduced to a much bigger view of nursing, and because I had so many concerns about what was happening to our nurses at the bedside. Went about writing this book just in the hope that I could empower nurses who are at the bedside to make the changes they need. And they're not huge changes, Tina. They are changes, could be small changes, like just maybe having an extra pair of hands, one extra nurse assistant in the unit, or having more resources, more thermometers, for example, to give nurses the confidence and to know that they are the experts in patient care and that they can meet with their leaders on the same level and request more help. Uh, to perform their jobs on the floor, we can do it, and that was the whole purpose of the book, was to empower nurses, give them tools to say, you are the experts, you have the expertise, you know what you're doing. Go ahead and speak with your leaders, because you could very well end up having, really changing the situation for yourselves and for your patients.
That's amazing. And yes, there are just so many things that we can do. And I just saw that it was, I think it's CDC came out with a recommendation for reducing burnout among clinicians. And it's the usual, I'm sorry, CDC, it's the usual fluff, right?
Right,
It
right.
doesn't get down to the real issue that you don't have enough staff and you're not taking care of the staff that you do have. If you solve those two problems, then the rest of them will be cake.
Absolutely, Tina. You are talking about the big conversation, the divider in the room, and that is nurse patient ratios.
Hmm.
Um, we know, we know that nurse patient ratios matter, and that nurses who have less patients are able to care for their patients better than those who have more patients. It just makes sense. It's common sense, really.
Well,
And yeah,
I was just going to say, we've been preaching evidence based practice, right, for years.
right.
And so when we have the evidence to back it up,
Yes, yes.
why
Countless
are you
papers.
why aren't you acting on it?
And when you look at it also, and I know we previously we discussed a little bit about this nurse model that I have in my book. It's a hybrid individual team approach to nursing, and it's very simple. So in California, where I work, you know that the nurse ratios in a med-surg unit and an oncology unit, pending acuity, are generally 1 to 5, and they're very good like that generally. Um, and so, if we could possibly have ratios like that, now these are CMS recommended ratios. These are not ratios that have been dreamt up by a nurse leader. CMS has recommended these in a perfect world. They obviously they can't mandate it, but they've recommended it. So we know if CMS is behind this, that it's evidence based practice. It's evidence based medicine. So if you have those that a team with one RN and 5 patients in a perfect world, and possibly one nurse assistant to work in that team, the whole of healthcare would, certainly in facilities, institutions, hospitals particularly, would change for the better, because now you would have 2 sets of eyes on those patients. You would have the nurse being able to do her nurse specific tasks, and you would have the nurse assistant doing their nurse assistant specific tasks. And the nurse, for example, and I know we mentioned it, in another, again, in a perfect environment, and I know there are plenty of states of nurses probably listening now who say, oh gosh, 1 to 5, we dream of that. But in a perfect situation, and we had 1 to 5, and we had that nurse working with the nurse assistant. They say there was an emergency, or there was something that the nurse needed to do immediately. They could go ahead and do it. They could have eyes on the patient. They wouldn't be giving 12 minutes of every hour to a patient for non-nurse specific roles, because that's what patients get. If you look at 1 hour with a nurse who has 5 patients, 12 minutes. 12 minutes. Now, that's not the time the nurse is in the room teaching the patient, checking in with the patient, talking about goals of care. That's the time the nurse has to be in the computer looking for orders, results, etc., etc. But if you had a nurse assistant there in the room, then that would free up that nurse to be able to do her specific tasks or his specific tasks. So the other thing that I mentioned also earlier on was the importance of having a nurse secretary at the nurses station. We have the most incredible charge nurses and nurse managers that work with us on the floor, but they generally are stuck behind a nurse's station, not because they choose to be, but because they are not able to leave the station because of nurses, because of phone calls or questions from physicians, questions from patients, you know, family members, etc. So you don't find them often in the ward, in the unit with a patient, one on one, unless there's an emergency. And it would be wonderful to have our charge nurses work with us more carefully, especially with the new nurses, when they are concerned that there might be some issue, to have the ability to go and say, hey, Susan, please will you check this patient with me? I feel there's something not right here, but I'm unsure. And then giving that nurse the chance to come in and help.
It's hard to do that when you're being pulled in so many different directions. As a person who was in that charge nurse and middle management as a
Absolutely.
supervisor, it's hard
It's
because
hard.
you're
Yeah,
responsible for what happens with the staff, but also with the patients.
right, right. And then when you look again at evidence-based medicine, you look at the cost of turning around nurses. Now, the last the last article I read, which was in the last couple months, was saying that the average cost of turning a nurse around is around 52,000 $52,000 to find the nurse, orient the nurse, and get them up and running. Now you think, nurse assistants, the average salary for a nurse assistant nationally is $36,000, as is a ward secretary, around $36,000. If we had ward secretaries and nurse assistants working with patients, I do firmly believe, and data has shown, that nurses will not leave in the numbers that they are leaving. There will be a better nurse retention. When there's better nurse retention, there are better patient safety scores. There are better patient satisfaction scores, which will reflect in revenue. So it makes sense fiscally to spend that extra money getting the auxiliary help for the nurses, because in the long term, the savings will be enormous.
That's true, because when you look at the costs that you have because of, let's just say, falls, and that's one of the things I've been, studying today, falls. Well, what happens if you have that extra staff? They're projecting that falls by 2030, I believe, will be like $1.2 billion a year.
Tina, it's terrifying. It's
Yes.
terrifying. And so, as the nurse, you're with your patient. You know the patient could fall. The patient has rung the bell and needs to go to the bathroom. You are not going to be able to do anything except help that patient to the bathroom. There might be other things. There might be a time sensitive, central line blood draw. There might be an urgent phone call, etc. But for safety reasons, you are there helping the patient.
Hmm.
Again, there should be somebody else that can help you with that. You should be able to go at 9 o'clock and do your central line draw. You should be able to go and contact that patient, and do some health education or whatever you need to do, and not be stuck doing those tasks because auxiliary help has been removed to save costs for the healthcare system you work in.
Yes, that's a problem. And then, of course, the when I started as a nurse, we had at my hospital what we call team nursing. So you would have an RN, an LPN,
Yes, I remember those
and a
days.
CNA, and we would all be a team in our own little pod, and we would have like 8 patients that we would take care of because psychiatry. I worked in psychiatry, but we would have our own little team, and then any treatments or any extra things that needed to happen, the LPN could help with those things. So that kind of freed up the RN to work on the care plan and implementing parts of the care plan that the LPN or the CNA could not. But then all that went by the wayside.
And it worked, didn't it, Tina? That care
It worked.
worked, didn't it? The
It
quality of
worked.
care we were able to give patients in a team with a nurse assistant or an LPN, it's so much better. It just makes sense. It just
Yes.
makes sense all round. And I wanted just to share with you, so Baker's Healthcare, Incredible Health, they've just done a poll, and I think it was a couple of months ago. But this is what nurses are concerned about. 73% of nurses are really concerned about staff shortages. That's, 3 out of 4 nurses are feeling it.
Hmm.
That says a whole lot. 70% are worried about themselves burning out. Again, why are they burning out? Because they're wearing too many hats. They 7 out of 10 nurses are really scared. I know, because I know compassion fatigue and burnout because I've experienced it. I know what it feels like. 68% are concerned about salary. 45%, and this is a huge percentage and something I was quite surprised about. So, almost half of the nurses working in America at the moment are really concerned about their work environment. And this speaks again to exactly what we're talking about, how the nurses are asked to work. When you have half of the nurses saying this is a major problem, this is a worry for me, hospitals and institutions who want to retain their nurses should be asking those questions. What do you need? What can we do to help you? And then there are 30% who have scheduling issues, and 25%, also quite surprising, 25% of the nurses are saying they have limited career advancement and choices. So that's another thing that healthcare could be cognizant about and think, this nurse is working in oncology. She's been in oncology for 10 years. She's saying that she is burnt out. What can we do for her in this hospital? We don't want to lose her. What can we do for her? Can we offer her transfer to another unit that might be less stressful or have less compassion fatigue than what she's experiencing now in oncology? There are ways around there are ways to work with nurses and retain them, definitely. And you and I both know that, and all the nurses listening on this call know that.
Well, you remember the concept of a clinical ladder. That
Yes,
was introduced, what was it, the late 90s, early 2000s. Hey, we're going to do this clinical ladder so that you can either go up if you wanted to be in management, or maybe make that lateral move, or whatever you wanted to do to cross train. We promoted to nurses that we wanted them to do that. But when it comes down to making the big decisions and having that seat at the table, we're still seeing a lot of nurses that are shut out.
yes, very
And
much so.
that's a big, big problem.
Right, right. And that's very sad, because let's face it, all of us, every single person who's involved in healthcare, we come to work because of our patients. If we didn't have patients, we wouldn't come to work. And so primarily our priority is always with our patient. And I have to tell you, I have to share with you, I had the privilege of meeting Bonnie Adario. She is a lung cancer survivor, and she has an amazing, she started an amazing foundation for lung cancer patients. Um, and she and I were sitting at dinner one night, and she said, "Look, Jennifer, this is what it boils down to. You should start with, well, nurses should think about this." And it would be, she would advise for us to start meetings with one question: is this good for the patient? If the answer is yes, this is good for the patient, then go ahead and have the meeting. And at the end of that meeting, you end the meeting with the same question: is this good for the patient? And if the answer is yes, you go about and you do what you said you're going to do. It's all about the patient. It's simple. And when we are prohibited from caring for patients because of the way we work, not because we want that or we are bad nurses, but because of how we are working, that is a major problem. It is always about the patient, and it's about time that all of us in healthcare focus on the patient.
Unfortunately, in modern healthcare, and certainly as I've seen, not just in the United States. So, those of you that are listening to other countries, Canada, the UK, wherever you may be, I've seen the complaints, and it seems to be that for-profit entities have entered into the equation. There's now some congressional concerns about this because we're seeing private equity entities buying up hospital systems that were nonprofit, and suddenly staffing patterns change. There's a lack of resources, even more than what we've seen before. And there's one particular hospital that was not performing the way they should, and now they're closing down, and they sort of left the community high and dry. And so these are systemic things that are happening all over. But I wanted to kind of go back to something, because you did say that you were at the bedside up until a couple years ago. So what made you make that shift and transition away from the bedside?
Tina, the truth of the matter is that I wasn't able to nurse the way I wanted to. And the reason for that was that, and I'm talking about personally, I wasn't able to care for patients the way I wanted to. Part of the reason was the work environment, but more important than that, at that point, was that I was burnt out, and I was starting to detach from patients. And when you are detaching from patients, um, it's a terrible feeling. You become numb. I can remember distinctly having a conversation with a patient that I knew very well. And I had spent a lot of time with this patient as an oncology nurse navigator. We continued relationships with the patients when, if they were having infusions, we would see them in the infusion center. If they were having hospitalizations, we would visit them at the bedside. We would be on phone calls with them. We would triage with them, etc. And so I knew this patient, an ovarian patient, ovarian cancer patient, and I'll call her Mary. I knew Mary very well, and she had progressed. She was stage 4, and she was about to start a new treatment. And we were sitting together, and we were going over some of the possible side effects. And she started crying because she'd had a horrific time with the previous chemotherapies and with previous side effects. And I was looking at her, and I suddenly realized that, gosh, it's like like I don't know you. That feeling, that
Mm-hmm.
that empathy
Mm-hmm.
is missing. And it was awful moment, because it isn't the type of nurse I want to be. You know, if I'm sitting with a nurse and I am weeping because I'm so terrified of a new treatment, I want that nurse to be 100% fully with me, compassionate and empathetic at the same time. And when you can't be, then I think, for certainly for me at that point, having been a nurse for over 30 years, I decided I need to move away from the bedside because I'm not providing the care that I want to. And it can become almost an existential dilemma, because I think of myself as a certain type of nurse, and that's who I've been. And now suddenly I can't be that type of nurse anymore, because I have burnout, because I have compassion fatigue. I'm not able to give that type of care. So does that make me a bad nurse? In my eyes at times, yes, that does. And I don't want to think of myself as a bad nurse. Now, I was lucky because I am an experienced nurse and I could afford to leave the bedside. There are many, many nurses who are, for whatever reason, especially our new nurses who are burning out, who can't afford to leave the bedside. So, what must we do for those nurses? We have to advocate as nurse leaders. We have to advocate fiercely for them. We have to call a spade, and we have to say there are problems. Evidence-based medicine shows it everywhere. And we know that these problems exist. And so, what are we going to do as nurse leaders, as organizations, as fellow nurses to help our colleagues? Because we are, as you know, we depend on each other, and our patients depend on us. And healthcare is at the point where it is going to break if there aren't changes. And we are the ones who must make those changes.
That's right. Nurses now are beginning to speak out more and more, and I'm
Yeah.
very encouraged by that. Those of you who are on LinkedIn, follow the hashtag nurses on LinkedIn, and you will see so many nurses now that are speaking out about the conditions that they're in. And even more encouraging, it's not just US based nursing. I want to
Yeah.
really emphasize that because I've seen nurses from Africa and different countries in Africa, and I've seen nurses in India, and I've seen nurses maybe not so much from China, but they've tried. So other
Right.
places that are really
Right.
speaking out, and I
Right.
think it's important. I think it's important that we
and
do.
and Tina, the other thing that I think is important, I know that one can get very, I mean, obviously we're all deeply concerned about what's happening, but there are many, many really shining stars out there
Hmm.
in the nursing world. Look at our nurse educators. They have a tough job, but they are showing up every day. They have compassion fatigue and burnout like everybody else. They are making a difference. They, we have tremendous nurse leaders who are in C-suite, working for their nurses. We have nurses from the newest nurse, from student nurses all the way up to nurses working in their, I don't know about their 80s, but no, nurses who have been at the bedside for many years. And the spirit of nurses remains intact. I think we're scared, and I don't think we talk enough about fear, the fear
Yes,
that nurses go through
yes,
at when they come to work. But the spirit is there, and the drive to care for patients remains intact, and that is what is going to sustain us. And so I think we need to shine a light too and recognize the fact that nurses are generally the most magnificent people that you will find.
yes. I wholeheartedly agree. And one of the things that I've seen is the negativity that nurses are experiencing right now from. Um, I'm just going to say it out there: malicious prosecution,
Hmm. And you
where
know better than anybody, Tina, because this is your bread and butter.
yes, yes. And I've seen cases where um, nurses are just railroaded because, oh, well, they made a medication error. Okay, well, how did the medication error come about? And, do we look at the systemic causes for this? So, yes, maybe an error happened, and unfortunately, the patient was harmed in some way. But what did it rise to the level of the nurse really being negligent and malicious? We have taken away that human error. Now, of course, everything's sensationalized now. So you have nurses that were obviously doing things for criminal intent. And so those cases get sensationalized. But I want to say, nurses still continue to top the leaderboard for the most trusted profession. And that says
Absolutely.
something about us.
That really says something about us. Yeah.
Hmm.
Yep. I think that, having worked as you have with nurses all my life, there is a bond between nurses. There is an understanding. My daughter is a labor and delivery nurse. She's been on the floor for 10 years. My sister is a registered nurse as well. We just have to look at each other. The nurse is on the floor. You're having a bad day. We understand each other like nobody else in the world. And I mean, it makes sense that would be the case, but
Yeah.
we do need each other. We do really need each other. And I'd like to bring up here, Tina, something that I think is incredibly important for nurses. So I have created a 4-step program in my book. It's a little different, and it's 4 steps for self-care. So it's a little different. It does obviously, and always should, and every self-help program for nurses should involve, obviously your stress reduction techniques, your diet, your exercise, etc., etc. Those are parts of it. But I think there's one specific part of self-care which is amazing and which we don't highlight enough, and that is the art of paying it forward. So,
Hmm.
step number 4 is paying it forward. Can you imagine if we all go to work and we know there's no bullying, we know there's no civility, we hear it, we see it all day. We not all day, but we see it on LinkedIn and in articles all day.
Yes.
And not necessarily, it doesn't necessarily happen in unit, but there are many units where it does happen. Say we go to work, and part of our workflow, for want of a better word, is kindness. It's inbred in us. It's in our DNA as a nurse. We do it all the time, every day at work with our patients. What happens if this then just spilt over into our relationships with our colleagues? What happens if we started looking at paying it forward as really part of our workflow, so that when a nurse needed help, they could ask somebody? Now, I know and some people have said, yeah, but when you're so task oriented, et cetera, it's difficult. But paying it forward can be as little as a smile, as smiling at a nurse, a new nurse, an old nurse, whoever, an old experienced nurse, whoever. um, just having that connection with somebody to show them that you care. Asking them, how are you, how was the weekend? It takes 30 seconds. We all know how to do it. We all love it when we can connect with each other. So have it as part of the whole work environment. And it's like we are investing money into a bank, and the bank is kindness. When we invest in the bank, tomorrow we can come back to Sue, who we've helped today, and Sue will help us, probably, if she can or he can. So these are just a couple of little facts that I wanted to share with you. So helping is can lead to, and I'm sure most of us are aware of that, because we do help and we feel good when we help. So help is high is a real thing. And when we help each other and our patients, we can get this help is high, sorry. And that results from an increase in serotonin, oxytocin, and dopamine in us, the giver. So there it is, right as rain. We are getting feel good hormones increasing in our bodies because we are helping somebody else. And again, as I said, they don't have to be huge acts of kindness, small acts of kindness. Just that smile, that hug, that I'm here, you can do this, whatever it takes. And then when you start getting into the habit of being kind to colleagues, these acts build on themselves. They become habit. It's just that you will greet, you'll smile, you'll laugh, whatever. You'll do that because it's part of who you are. It's part of how you work with the others. Kind people have 25% less stress hormones in them. And this makes perfect sense, because when you are cross and angry, we know what we feel like. We know how much stress, what our cortisol, etc. levels are when we cross and stress and angry. But when we're kind, they can drop by 25%. Kind acts improve our own self-worth and improve our purpose in life. So, I mean, that's amazing. And it takes a person out of their head. So, and the lastly, when you are kind, you get to stand apart from the people around you. And when the next job promotion comes, they'll know you because you're kind. So that was just something that I've researched that is very important to self care.
Well, speaking of research, and you've mentioned your book a couple of times, give us the titles of your books and how may our listeners get a hold of them.
Okay, so Nurses Matter is the recent the book that I've written recently. I wrote a book in 2016, not for nurses but for oncology patients, called Navigating Your Cancer Journey, and that was under my maiden name, Jenny Marais. But this book now is under my married name, Thietz, as you introduced me, and it's called Nurses Matter. It's available on Amazon, and it's available in either a Kindle or ebook or a hard copy. Not a hard copy, a soft copy, because it's not a hard, doesn't have a hard copy binding, but soft copy. You can get that as a book as well.
That sounds wonderful. So, again, give us the title of the book.
So it's Nurses Matter, and it can be found Nurses Matter with my name, Jennifer Thietz, on Amazon.
So, you heard that here. Everybody go over there and get the book so you can read it. And not only read it, but I always like to say, implement what you read. We don't just read things for entertainment, but this is a great way for us to learn how to improve our own working situation and take ownership of the problem. Now, granted, there's certain things you can't change. You can't go give yourself a raise. If you do that, that might cause some problems.
Unfortunately.
Yes. The only way you can give yourself a raise is to become an entrepreneur.
There you go.
Don't forget that opportunity out there, but you can be entrepreneurial even at the bedside in your thinking and how you can improve the situation in which you find yourself on your unit. So I want to thank you for your time, Jennifer. It was great and wonderful talking with you. I'm excited to get a copy of your book. I haven't had a chance to download it yet, but I will. And so for our listeners, please make sure you do check out our book. I think she's got some wonderful things in there for us as nurses. And then also don't forget, for those of you that are watching this video on YouTube, to like and subscribe and ring that notification bell so that you can be notified every time we have a new episode. Also, those of you that are listening to us, you can check us out on Podbean and get your podcasts wherever you get your podcasts, Spotify, Apple, etc. We are on all the major platforms. And then we also ask that you leave us a comment and let us know what you're thinking about our episodes and how we can further support you as nurses out in the field. And then lastly, if you're a nurse and you're a nurse business owner or author and you would like to be featured on the show, please reach out to the Nurse Shark Academy at the nursesharkacademy.biz, and we'll be happy to reach out to you and set up a time to talk. That's it for our show today. I want to thank you again, Jennifer, for being a wonderful guest.
Tina, it's an absolute pleasure. Thank you for the work you're doing for nurses everywhere. We appreciate you.
All right. Thank you.
All right. Thank you. Bye-bye.
Tired of feeling trapped in a job that no longer fulfills you? Is your nursing job no longer the fun-filled adventure you imagined? Find your passion again through nurse entrepreneurship. Step out into the light and come feel the sun. Join the Nurse Shark Academy today at the nursesharkacademy.biz and come feel the sun. Thank you for listening to the Nurse Shark Academy show wherever you get your podcasts or watching us on YouTube. Don't forget to like and subscribe, and don't forget to hit the notification bell so that you'll know when all of our episodes come out. If you want further information, you can contact us on the nursesharkacademy.biz.